This is Heart Rhythm TV, and I'm Daniel Alyesh here with breaking news. The Asia Pacific Heart Rhythm Society occurred very recently, and we received very interesting longitudinal data in the world of PFA with regards to coronary arteries and proximity for delivering PFA energy. And for that reason, I'm joined today by Dr. Mark Tam of the Chinese University of Hong Kong. Welcome.
Thank you. Thank you, Dan. It's my great pleasure to be invited in the APHRS TV.
Well, thank you for adding this piece to our literature. 19 patients studied with OCT with PFA delivered with the Pentas line catheter with proximity to the coronary arteries. And your findings were extremely interesting to our viewership and all viewership. So, I'll start off with a question for you, the impetus behind performing such a study. Interesting preclinical data performed, understanding the long-term impact of PFA when delivered close to coronary arteries. Can you tell us a little bit about that preclinical data and the histological findings?
Yeah, thank you. So a couple of years ago, we have animal studies published by various parties. So I listed here two studies showing that if we perform any PFA in animal models epicardially, then in the histology, we quite often see this kind of fibrosis inside the wall of the heart artery, leading to increase in the wall thickness and reduction in the coronary luminal area. As shown here in the figures by Niven's team and also Higuchi's team, showing that there is tunica fibrosis in the media and also neointimal hyperplasia. And particularly for Dr. Higuchi's study, they have been able to show that this affects majority of the vessels after application of the PFA. It affects like 7 out of 8 vessels. So it's kind of important effect of the PFA on coronary artery. But we were thinking, because we're ablating from the endocardial side, and theoretically speaking, it's maybe further away from the coronary arteries. So maybe we can be protected by this kind of long-term effect. But this is counterbalanced by the fact that especially when we're doing CTI ablation, we hook the catheter and we pull down the catheter by applying quite a bit of pressure. And the contact is excellent when we do that kind of ablation. So I'm not sure if the effect of the endocardial PFA ablation will be the same for epicardial PFA ablation. Hence, we conducted this study.
Absolutely. So mechanistically, we're seeing fibrosis, we're seeing hyperplasia, and we need contact to deliver an effective lesion. But what are the downstream consequences? And I think to counterbalance some of your data, in Jackie P. just this year, Maishlev et al. Published this study looking longitudinally at coronary angiography at areas of PFA application with vasospasm. And they did not find any angiographic difference, excuse me. But you take it to the next level, bringing in the concept, which the authors allude to in this study, of using something even more precise, like OCT. And so I'll ask you to elaborate, what is OCT for the EP viewership, and how did you apply it to your study?
Yeah, thank you. So we all know that traditional coronary angiogram has this limitation because we're looking at the vascular diameter instead of the vascular area. So if we want to do more precise measurement, the vascular area would reflect the overall change in the vessel in a more accurate way. So the way that we do OCT is, OCT is a very common investigation that the interventional cardiologists use for PCI procedures. When we do that, we will wire the vessel and we will give nitroglycerin. And then there's an imaging catheter that's being passed to the distal vessel. The imaging catheter can emit light, which got reflected from the vascular wall. and then interfere with the light itself. The OCT catheter measure this interference to deduce the distance between the vascular structure and the imaging catheter to give us the cross-sectional image as shown here. So when we do the OCT, we'll flush in contrast to flush away all the red cells that would obscure the vascular wall structures, and the catheter will also mechanically pull back by pressing the button. So it can collect a cross-sectional area, cross-sectional detail, and also the longitudinal detail as well. So that's how we do the OCT. So in this study, we will do 3 OCT for each enrolled patients. The first OCT will be done before we do any ablation. So after we completed the PVI, we will give nitroglycerin, we'll wire the vessel, and then we'll do the first set of OCT. Okay, and then the second set of OCT will be done after we applied ablation, and when we see spasm in coronary angiogram. Okay, so so that collects the second set of OCT data, and then after 3 months after the ablation, we will bring the patient back to the cath lab to do a third set of OCT on the same vessel. So when we do the analysis, we want to make sure that we are analyzing it fairly, and we are analyzing the spasm site exactly for all 3 runs of OCT. So how we do it, first of all the measurements are performed offline. The interpreter would first look at the spasm run. So that would be the second run of OCT. In that run, he will be able to identify the site of spasm, and he will also decide a site of reference remote from the ablation that serves as a control to let us know whether there is any change at 3 months. And he will measure the distance between this spasm site and the bifurcation landmark. So for example, for RCA OCT, that distance will be the spasm site from the bifurcation of the distal RCA into PLV and also PDA branches. And then the OCT interpreter will be blinded when he or she measures the other runs of OCT. He will not know whether the other run are taken before ablation or at 3 months. He will use the previous measured distance to determine the site of spasm that has occurred or will occur, okay, from the other run of OCT. Likewise, he will also define the reference site using the distance from bifurcation landmarks. So showing in the right panel, you can see the cross-sectional image that we can get from a vessel. And you can see we can look at the lumen, and we can also see the vascular external elastic lamina that defines the media of the vessel. So when we do this study, we measure 2 things. One is the luminal area, which is bounded by the white circle. And the other is the vascular wall area, which is sandwiched between the blue circle and the white circle.
Well, excellent. So really this takes it to the next level where you can actually measure multiple aspects of the vessel, understanding the diameter, understanding the circumference, and understanding the wall thickness. So I think this goes beyond traditional angiography. But there are some correction factors related to vascular tone, which you all did, as you can see with the equations below, and I think very helpful. But in the interest of time, I think we'll move on to a few questions that I have for you. Number one is, I think intracardiac echo, I'm very biased. My first question is, was intracardiac echo applied at all in this study? I'll just say that in the US, a lot of us are visualizing the CTI with intracardiac echo. And then in this case, as you can see in this circumstance, the RCA is very visible and somewhat subendocardial. So in this circumstance, I would probably not apply PFA energy.
Right.
In the area of RF, if I see this situation, what I typically do is clock or counterclock. And you can often find a septal or lateral path that avoids the RCA. If that is still impossible, I often will drop the power and change how I apply my lesions. So was intracardiac echo applied at all in the study?
No, it was not. I wish we have the resources to do it because it's quite expensive in our locality. We did it when I was in Michigan as a fellow, but in Hong Kong, we do not have the luxury to do it. But I would argue that for the pentaspline catheter that we use for the PFA application, it may not be easy for us to avoid the RCA because of the bigger footprint. Unlike when we do the RF, it is a point-by-point catheter, we may be able to select another CTI line, more septal or more lateral, that can avoid the RCA. But I think for the pentaspline catheter, we may not have that choice.
No, it's a large footprint, and I think it becomes very difficult to avoid even with ICE guidance use. The choice is to use it or not, and to use a different energy source potentially. And also, Mark, go blue. I remember you were a fellow, a senior fellow when I was a general fellow there.
Oh, right.
Yeah.
Oh, right. Yeah.
Yeah. So, the worlds collide. But back to our discussion. So, were you able to get a sense for how far your pentaspline catheter was from the coronary to give us a sense for, what your distancing was? Because, that will be the next step, will be to understand what is safe distance, what is safe dosing. Were you able to get a sense for proximity at all quantitatively?
Right. Yep. So in coronary angiogram, we can have a rough estimation of the distance between the RCA and also the catheter, but that's a qualitative measurement instead of a quantitative measurement. And the distance that we see in a coronary angiogram may not be so accurate because of all those foreshortening because of the viewing angle. In OCT, we're not able to see the distance between the OCT catheter and the ablation catheter because of the limitation of the OCT.
Well, thank you. I think that's helpful. And again, I make this point on this program all the time. The fact that ICE is a cost limiting factor everywhere else is a real problem, because I think that you did a wonderful study, but I think if you can real time visualize where your catheter is relative to coronaries, this will also add value.
Yeah, I agree.
So moving on to your results section, I think very interesting. And I ask you to comment on this first slide here. You gave 800 micrograms of intracoronary nitroglycerin, but you still had a fair amount of severe vasospasm. 45% of these patients have applied. Can you comment on that and comment on your protocol there?
Yeah, so we give intracoronary nitroglycerin for all patients before the ablation, and the dosage of nitroglycerin is determined by the blood pressure of the patient. So we aim the TNG dose that brings down the blood pressure to around 80 millimeter mercury systolic blood pressure. And many of the times it would be difficult for us to give a higher dose because of the pull down blood pressure in general anesthesia. And we saw quite a bit of spasm despite this dosage of nitroglycerin, which is not. This is quite surprising to me because Dr. Vivek Reddy published in Circulation saying that if we give 1 to 2 milligrams, so that's 1,000 to 2,000 microgram of TNG, then most of the severe spasm can be prevented. So I attribute this to, first of all, maybe we're giving a lower dose than what he did in his study. And also, our patient group is maybe different from his because we are doing it in Asian populations and our heart size is smaller and the distance between the catheter and the vessel may be smaller, hence the greater effect of the PFA on the vessels. And also because we were measuring the area instead of the diameter in coronary angiogram. Area is the square of diameter. So when we say we have more than 70% of reduction in coronary lumen area, that is corresponding to around 50% reduction in the diameter. So that perhaps tells us why we see a difference.
Well, thank you for that. I think maybe it harkens to how you performed your study and the heightened precision and sensitivity of OCT. I want to ask you too, how many applications with the pentapline catheter were you performing on average at the CTI?
So in this study, we do 90% of patients do CTI ablation and 2% had mitral isthmus ablation. And the average number of applications is 9 applications. So we usually do 3 applications per site, and then we go to the other site.
So I think this is the punchline and quite profound. Tell us what you found at your 3-month assessment of the OCT of the cross-sectional area of the coronary arteries that had experienced vasospasm.
Yeah. So first of all, at the ablation spasm site, we found that the vascular wall area has increased by a median of 17.1%. That's shown in the left panel here. And the right panel, we also see that the vascular luminal area reduced by a median of 10%. And this is a change after we applied the correction formula that was in the previous slide that corrects the vascular tone change. And not shown in this slide, we also measure the change in the reference site, which showed that there's no change in vascular wall area and also vascular lumen area in the reference site remote from the ablation.
I mean, that is, in a word, very sobering to see what you found. I guess I'll ask you clinically, because you're using a more sensitive metric here, but clinically, did this manifest at all symptomatically in the patients at 3 months?
Yep. So all these patients are asymptomatic without any MI or some of them have chest pain after ablation, which is I don't know if it is related to the ablation. I mean a lot of patients had a bit of pain after ablation, right? So but none of these patients developed real myocardial infarction or ongoing chest pain when we follow up these patients.
So here's a specific patient example that you give us, kind of illustrating your protocol and the changes you see on OCT. Can you walk us through this slide?
So yeah, so in the left panel, you can see coronary angiogram and OCT for a patient before the ablation. In the coronary angiogram, you can see the RCA, there's no irregularities and no stenosis at baseline, which is also demonstrated in the OCT, showing big vessels and thin vascular wall. In the middle panel, you can see that during acute, after the ablation, we do a second set of OCT, which demonstrated acute spasm in the distal RCA, as shown in the coronary angiogram and also in the OCT, with a marked increase in the vascular wall thickness and vascular wall area. In the right side, you can see the 3-month data showing that in the previous spasm site in the distal RCA, you can see a bit of reduction in the vascular lumen in the previous spasm site, which is also seen in OCT with increase in vascular wall area and also reduction in vascular lumen. And interestingly, this patient also had a LAO done after the PVI OCT and PVI procedure. So you can see the LAO in the 3-month angiogram.
So Thank you. I think you can see the changes angiographically at 3 months, unlike in the previous study. And you also can see significant changes on the OCT. I'm not an angiographer. I don't perform OCT, but I can see that. Yet not clinically significant as far as symptoms go.
Yeah.
Pathophysiologically, I think the story has yet to be written about these areas of fibrosis and hyperplasia. Does this also correlate with atheroma plaque and acute coronary syndrome or coronary artery disease? We don't know. Or do we know? I guess that's also a question.
Yeah, so I think the big question is down the road, will these patients develop progression of these lesions, or will these patients have some kind of healing in the vessel and have a improved flow in the artery? So there's a big question mark here.
Absolutely. So I guess I'll ask you to just summarize your final conclusions. Thank you again for performing the study.
Yeah. Thank you. So first of all, we found that despite we used nitroglycerin preemptively, we still observed coronary spasm, and it is quite common after ablating near the coronary arteries. Secondly, 3 months after endocardial pulse field ablation, we found a statistically significant increase in coronary vascular wall area by a median of 17.1%. And this was not seen in a predetermined reference site remote from ablation. At 3 months, we found a statistically significant reduction of vascular luminal area by a median of 10%. And this was also not seen in the reference site. So we conclude that, and we also found that while the effect was mild for most patients, we still observe significant long-term luminal reduction that happens rarely. So we conclude that while intracoronary vasodilator therapy may prevent or treat acute spasm, the risk of arterial stenosis remains, calling for heightened vigilance and longer-term follow-up.
Thank you. Thank you very much. Congratulations on a great study.
Thank you, Dan.
I think that it's clear that in the area of vasospasm, relative to controls, this is where you see this change.
Yeah.
And it's a change that persists at 3 months, which is very interesting. I'll mention that, we have 19 patients, we have 3-month follow-ups on your study with clear changes on OCT without clinical significance that we know of. I think we need to understand what this means in the long term. Does it regress? Does it get worse? Does it promote coronary atherosclerosis or atheroma or anything like that? It's hard to say. Also, the broader question is dose dependence. Like when we talked about coronary arteries and RF, especially in the LV summit region, we talked about 5 millimeters and understanding that distance, understanding power settings. I guess I'll ask you, moving forward, Mark, do you anticipate us finding a dose dependence, finding a safe distance, finding an algorithm, maybe a coronary safe algorithm? Do you see that as possible in this era of PFA? Because, we don't want to trade CTI flutter for significant coronary artery changes that could result in significant clinical syndromes.
Yeah, so I think this is probably dose dependent and also dependent on this depends on a couple of factors. First of all, it depends on the energy dose and energy waveform, right? The PFA is quite tissue specific, and how we tweak the waveform and the frequency, the wavelength of the energy also may affect the overall result on the coronary. And hopefully we can find a protocol of how we can do it safely. Or the other way around, we know that some of the industry partners are developing dual energy catheters that can be used on these flutter lines. And hopefully we can have a choice of selecting which energy that we can use when we are in close proximity to coronary vessels.
Yeah, I completely agree. It may be that the size of the catheter or the algorithm will need to be changed around this. We don't know. But again, thank you, Mark, for a great study. Go Blue.
Thank you.
I'm very glad to see you doing such great things in Hong Kong, and it's fun to see where you've come relative to when we were fellows.
Right. Thank you, Dan. It's great to see you again. And yeah, thank you.
And thank you all for tuning in to Heart Rhythm TV.